Thank you, Calcivis, for inviting me to speak here today. Real privilege. And I will rattle through some slides for you in the next sort of 15 minutes or so, really just essentially backing up a lot of what Nigel has just sort of introduced very, very nicely, very eloquently. So we've got to remember why we exist. And we all exist because ultimately we want to help prevent and manage this condition. I use this slide a great deal, and I always ask what's the most important word in red to any audience, whether it's undergraduate, postgraduate, whoever it might be. And everybody sees the P word, prevent, and thinks that's the critical word, and it isn't. It's helping, because unless you own that mouth, you can't prevent it. All you can do is help somebody. And you can help by practicing MI dentistry. Again, I showed this slide yesterday in the presidential symposium, and I do not apologize for showing it again, and I will keep showing it until the day I die, because it's really quite critical that people understand the terminology, because it's terminology that's being used a great deal. I was just having a discussion this morning. IADR 10, 15 years ago, we had a few presentations on MI. Now, half the program has got MI in it somewhere, which is fantastic. It's exactly how it should be. But we've got to make sure we're talking about the right things. Minimum intervention care, you can read it. I'm not going to read that to you, but it's that holistic overall approach, patient-centered with all these different factors. And then you're looking, oops, sorry, why isn't that moving? There we go. And then we've got minimally invasive dentistry. It's this sort of surgical skill set, cutting small holes, all that sort of aspect. And the practitioner is moving away from the dental surgeon, that mechanistic approach, into an oral health physician. We've seen COGS already. Only difference between mine and Nigel's is that my COGS just about link up, and that takes a heck of a lot of time on PowerPoint. It's a waste of 4 hours of my life to do that, but there you go. The principle here is exactly what Nigel was saying. We have to, as a team, identify what the problem is, risk assess it, care plan it. We've got to prevent and control it. There are different members of the team, oral health educators, dental care professionals, practitioners. This is the whole critical process. We still have to restore teeth. We have to put fillings in teeth. It's not a bad thing. We do it minimally invasively, and then we recall patients. We've got to embed the patient in the center of this whole process. So the aims are to look for susceptibility of our patients to the risk, to the caries process. We need to empower patients and get them to value the care they're receiving, get them to take responsibility. Not easy. None of this is easy. And these are some of the barriers there, and we've got to be pragmatic. So the barriers that we have to oral health care, I've summarized. We've got to think about how we educate the profession and how we practice dentistry, how we change that from traditional approaches to more modern ones. We've got to look at healthcare models, the business modeling, the public, and also research. And again, I appreciate Nigel has actually covered this, which is why I'm going quite quickly. Undergraduate curriculum. It's a big, really important aspect, and I know there's many, many universities represented here from around the world, and we're having more and more conversations about how we actually unify the teaching, how we put this information across to all the levels of student, both undergraduate and postgraduate. We need ratification from sort of governing bodies in different countries to do this. And really, dare I say it, start to shift from the traditional approaches to the contemporary ones. The evidence is there. It's how do we actually make it happen? We appreciate what the traditional sort of knowledge base of how a caries process develops into the lesion and then damages the tooth. And classically, in terms of management and care, it's always come at late stage. We're already looking after teeth when the damage has been created. Sophie Domijon did some excellent work actually now about 14, 15 years ago, where they assessed the level of practitioners around in France and in other countries in terms of intervention. So you look at the images at the bottom, the question essentially was, when would you pick up a drill to do something? And you can see the shift there to the left, i.e. really quite early intervention. 1995, 96, you can see the Scandinavians were ahead of the curve. We're redoing these studies now, and fortunately, the bars are shifting more and more to the right, which is what we want. So the message is slowly but surely getting through, which is very positive. And it's all about tackling the problem right at source. And as Svante said yesterday, it's not just about mopping up the floor, it's about also turning the tap off when we're looking at sort of at managing. So myths and mendacities. We seem to think, or certainly there's a proportion of us, not necessarily in this room, not necessarily in the Excel Center, but certainly in our profession globally, that think that if you pick up a drill and cut a hole and put a filling in a tooth, you're curing the problem. We're not. We all know that, but unfortunately not necessarily all the profession do. And then you get issues like this where people chase lesions and just riddle teeth with different filling materials. We've got to think about prevention. A number of times I've had practitioners telling me prevention doesn't work. It does work. It's not always easy. Changing behaviors, changing attitudes is incredibly difficult. No one is suggesting otherwise, but just because something is difficult doesn't mean we don't tackle it. We obsess about restorations. We're the only healthcare profession that worries more about the prosthetic that we place in the patient as opposed to the actual biological tissue. Go on PubMed and look up longevity of restorations, you'll probably find 50,000 papers. Look up longevity of pulp, not so many papers. So it is that biological response, the tooth restoration complex. It's not about which material is good, which material is bad. We've got minimata, amalgam eventually will be phased down and out, and we've all got our opinions on that, but that's the way life is. But it doesn't imply that composites are fabulous and GICs are amazing. The amazing bit are the people using the materials and the people looking after the mouths that the materials are in. That's the critical bit. We all suffer from this. We've been taught by great people over the years, and we want to believe in what we were taught, but things move on, and we mustn't be frightened of that. And I certainly remember when I was being taught this dentistry 30 years ago, when restoration is leaking or cracking, we cut the whole thing out, make a bigger hole and put a bigger filling in, i.e. the restorative death spiral. Not necessary. We can repair, and that's what we should be doing. So, susceptibility, and this, as Nigel said, ties in with activity assessment, which is where we're coming round again. And there's all these factors to consider in terms of care planning, the minimally invasive techniques, engaging patients, all the chemistry there that we've got on the screen. So patient-operated factors, histology, and the chemistry of the materials. We tie it all together, we've got MI dentistry. Healthcare delivery models, a real issue, and which is why policy labs are so important, which is why getting the right people to attend the policy labs is so important. We look at the Adult Dental Health Survey in the UK, published now nearly 10 years ago, and there were some positives there, no question about that. But there were also plenty of concerns, and if you notice a little acronym I've changed from National Health Service to is it actually a National Illness Service? Because the service is there to treat illness rather than maintain health. It's a moot point, but there you go. And there are inequalities and low levels of reported preventive advice. Appreciate this is 10 years old, not disputing that, but this is the issue we have. There are barriers. We've got to think about how funding is going to change. I appreciate this is a very UK-centric slide, but every country will have its own equivalent slide like this. And whatever your politics are, I'm not trying to get into this now. We're not even going to go on to Brexit and all this fun games that we're having, all right? But we have to think about these points that are coming up on the screen here in terms of workforce development, corporate dentistry, variation, international, regional variations. It's a very difficult problem, and it's not easily solved. But as I said, just because something is difficult, it can't be overlooked. Practice modeling, the traditional concept of healthcare delivery, you know, the dental surgeon working in a solitary surgery, trying to do everything. Those days are gone, and probably quite rightly too. We've got to think about the business modeling, that having coordination, working with industry. Again, this is something that's happened, really developed beautifully over the last few years, and which is why we have symposia like this, because the stakeholders need to work together on this rather than always separately. We have to think about ethical marketing, but advertise health, not advertise procedures to do. But it's a bit of a mind shift in terms of the profession and the public. And that leads us onto the public, our patients, our clients, our customers, our consumers. And that's what we're calling them now. They have a lot of power. But unfortunately, as we know, dental caries is a lifestyle-related disease. Therefore, unfortunately, most of the patients who are suffering from it are suffering because they've done something to themselves. And we can't fix that. They have to fix that, so we have to engage with them. So they have to value. The recall consultation. In the UK, this is called a checkup. Awful terminology. Think about it. If the profession is undermining its own value by using the wrong terms, why should the patients value it? It's not a checkup. It's a consultation. It's the most important visit. It's the most important part of care. It's to review their behavior change, review the treatment that's been carried out. And it's changing that mindset that's critical, and it's communicating it. And research evidence. We are only ever asked to provide research evidence for things people don't want to do. All right? Think about that. People want to change something, they'll go and do it tomorrow. They won't ask for all the evidence, they'll just go and do it because they think it's right. But the moment people are resisting, they'll want all the evidence. There's no actual evidence that parachutes work. Show me the clinical trial. Okay? But we all believe in them, and we know they're right. There's no evidence that amalgam is so fabulous and fantastic that we've needed to use it for the last 100 years, but we have. So we've got to really be pragmatic about how the research is done. Clinical trials have some value, of course they do, but they're not the answer to everything. And just because we have low evidence levels for most of what we do in dentistry doesn't mean what we do doesn't work. And that's a really important concept. We were discussing this at the symposium yesterday, and there's been many people talking in different sessions about this. We can't always provide high-quality evidence for everything, but it does not mean that what we're investigating is wrong or doesn't work. So, from an educational perspective, education never stops. We start at year 1 at dental school, and we carry on till you retire and beyond. And so we have to sort of tie all this together, and having a symposium like this where Nigel and I have sort of set the scene, we can now then move into more of the detail behind that sort of detection aspect. So with that, I'd like to thank you for your attention, and we can move on to the next presentation. Thank you.